With that, I'd also like to thank our generous funder, the William Girls Swigert Fund, continues to make this possible and make it free to everybody. So with that, I turn it over to Doug to kick off the main event.
Oh, thank you very much, Deborah. Is my audio okay?
Yes.
It is. Excellent. And you can see my slides? Yes, thank you very much. Okay, so today we're going to be talking about and role-playing the very important subject of talking about medicines. And this is let's see, where are we here? This is session number 5 of our webinar series. And just note the new date for the next one. We're actually missing a month before coming back at the start of July. So why is talking about medicine so important? Well, it's certainly one of the main topics for psychiatrists when they're speaking to their patients, their clients in the clinic or in the ward round, or in the community mental health team. And very often that appointment is quite brief. It's maybe only 10 or 15 minutes. And in that appointment with the psychiatrist, there is a need to review risk, check in on symptoms, and then decide if anything needs to be done with the medication. Does it need to be reduced, increased, or changed? So it's obviously going to be quite a busy 10 or 15 minutes. And then the patient will go back home to discuss with their family the things that have been said. And unfortunately, often it is so rushed that the patient has forgotten a lot of what has been said or can't quite remember the detail. So for this reason, talking about medicines is a very important subject. Now, one of the main reasons that people don't take their medicines across severe mental disorders is, as the song just said, they don't think the drugs work. In actual fact, the medicines are the cornerstone of mental health treatment. And the effect size of mood stabilizers and antipsychotic medicines is strong. And we score it at about 0.4, which means it's a moderately strong benefit. It is a major contribution to recovery. And to that moderate effect size of medicines, we add CBT, with an effect size of 0.2, and family therapy with an effect of 0.2, and then you're right up at 0.8. And at 0.8, you're almost expecting recovery. It really should be happening. So medicines are an important bit of achieving recovery with mental disorders. It is only a 15-minute appointment. I'm not sure about US psychiatrists, but in the UK, we've been squeezed down now into a 15-minute appointment. And what I do now is I say to the client, bring your phone with you and let's record our discussion about the medicines. And then you can take the recording away home, play it to your family, have a full discussion about it, and make a note of any questions for next time. Now, this idea of recording the discussion is a major advance in improving adherence with medicine. Because what we need to do is we need to shift from all the power being with the prescriber to the power being shared between the prescriber, the patient, and the family. And once the power is shared, we then have collaborative prescribing which we know people tend to take their medicines much better. So how we talk about medicines is actually very, very important. In terms of medicines for anxiety and antidepressants, these are slightly less effective than medicines for schizophrenia, psychosis, and bipolar. They are still very, very useful. They're just slightly less effective. So in those conditions, the psychotherapies are even more important. Now, must be said that psychiatrists are deluded. I don't want to be quoted in that, but the reason I say that is that we actually believe that the patients we see in clinic take their medicines. Now, the evidence surrounding this seems to be that less than half of the patients coming to the clinics take enough of the medicines to prevent relapse. So as psychiatrists, we aren't actually having that conversation about the medicine in an effective enough way that the information is absorbed, goes back to the family, and leads to a viable adherence with the medicine. The power imbalance needs to be fixed, become more collaborative. But then again, there's strange things about adherence. There is a pill box that plays a tune. And the pill box starts off to play this tune when you're due to take your medicine. And it came up with a top rating as one of the most powerful adherence supplements. You buy a pill box, set up this tune on it. When the tune goes off, the loved one says, "Oh no, it's time to take the medicine again. There goes that stupid tune." And they actually do, because a lot of adherence is just because it's been forgotten. So adherence and taking medicines is a very interesting subject, and one in which there can be dramatic progress made within the home environment and within the clinic. And that's what we're going to be talking about today. So this is what we're going to try to cover. We're going to try to cover the basic principles of why people do or don't take medicines and other treatments, because adherence is a problem across every disorder, mental or physical. Lots of people have their medicines and they take them intermittently or not at all, or they just store them in a drawer where they're not going to be doing much good. So it goes right across medical practice. This is a very important area. We know that families are really important in terms not only of recovery in general, but whether medicines get taken. So this dialogue about medicines is going to be happening around the world in homes where there's any kind of illness. How do we help our loved one take that medicine, whether it's for blood pressure or asthma or depression or whatever it's for? What is the best way to talk about it that is liable to yield a result? So we're going to do a role play to kind of give an example of what can go on there. Automatic thoughts about medicines. At one time I was diagnosed with asthma, and I was given a brown inhaler, which was a steroid, and a blue inhaler, which was salbutamol. So you would think a medic would be sensible, but no, not at all. What I did was to use the blue inhaler, and I completely ignored the brown one. Now, the brown inhaler is the steroid prophylaxis. It means you don't have to use the blue one. So doctors are bonkers about taking the right medication. And the reason was, I went to the clinic, the nurse said to me, look, why aren't you using this inhaler? And I thought to myself, what is my thought about that brown inhaler? And I thought, yeah, I don't think it works. I don't think I need it. So I just told her the truth of what I thought, and she showed me the evidence that it really does work, and I needed to really try and give it an opportunity. A 2-week trial. I gave it a 2-week trial and it worked, but that was years down the line. So doctors are not great at taking the medicines we prescribe, but all of us need to ask ourselves that question: what's going through the mind when you think about that particular treatment type? Because very often the thoughts that you unlock aren't actually all that rational, but we should try and catch them. Whenever you look at that appointment card to go to the clinic to get your blood tested for lithium, what goes through your mind? What is the thought that's there? And it's amazing the things that you find out that people are thinking about their treatment. But there's family rules, there's health beliefs that people have, and then there's culture. And these are all powerful factors as to whether people do or don't take medicine. You get rules running in a family. We don't really take medicine, you know. In our family, we like homeopathic treatments and we like natural treatments. We don't really like tablets in our family. You got other families who say, yeah, we've had great success with tablets. We endorse them. If you get prescribed it, take it. And that's kind of dichotomous, you know, families that are pro-treatment, pro-medicine, and families that are like, nah, let's be natural. But sometimes that isn't stated. It's just something that is in the family. So perhaps we need to have a look at our own family rules about medicine, because for a loved one growing up in a family, they've absorbed these rules. And while it might be unspoken again, it is there. And we might want to make a special effort to change it or to correct it. We've all got our own health beliefs as well that come from our own personal history of having illnesses of various types and whether they've responded to treatments or not. Cultural aspects are massive and again, unspoken. Now, you've prescribed that tablet to me. I've taken it home and I've found out that it is not halal. And I am really not happy with you for doing that to me. So what is actually in these tablets? Are these medicines acceptable to different cultures and different faiths? Now, there's a thing called the Medicines Compendium, which is the only place you can find out what exactly is in the pills. And some of them aren't acceptable to various faiths because of the ingredients that are in them. Now, very, very often people from those faiths will work that out they'll go and investigate it and say, no, this isn't for me. Not come back to the clinic, ditch the medicines. Adherence is gone. So we as prescribers need to be smart enough to know what's in these medicines. And I think this is an area that is widely neglected. So having gone through all of this sort of stuff, I'm going to show you a video of the way I do my prescribing interviews, the way I talk to my clients about starting a medicine and taking it, perhaps the way it might be done, where the power is shared and it becomes a collaborative endeavor to hit our joint goal, which is better health. So we're going to talk a bit about the techniques you can use to aid the adherence discussion, and there's a whole variety of these. And you don't want to do them all. You want to use the one that seems best in your setting. And there's going to be some question and answer stuff going throughout. So I hope that's going to be interesting for you. I hope there's going to be something there that you'll find you might be able to use somewhere in your own family situation. Right, so what are the basic principles of adherence or concordance? But these are the same words. I mean, the old word was compliance, but it was deemed that was an unbalanced word. It then became adherence, and now it's concordance. So concordance is meant to be collaborative. Now, one of the key things that I always do is to not jump straight into the medicine. So I kind of disarm the discussion by talking about other possibilities. So I'm going to speak about the spectrum of possible treatments. I'm going to introduce that spectrum to my patient, my client, and say, these are the kind of things people have tried, and these are how much success they've had with these different approaches. So can you treat a psychosis with a cultural treatment, perhaps a special type of tea, or by having a religious ceremony? Well, I think I should go there and discuss that. The only problem is there time to do this? If there isn't time to do it, the person might be putting their prescription in the bin. So I try to make time to discuss this range, because it may be that the person in front of me didn't really want to come and see me. And what they really wanted was to go to a local religious shop and get a special tea and take the tea because that's what they think is really going to work. So I should talk about that, find out what's in the tea, be interested in the spectrum of possible treatments. Can you treat bipolar by changing lifestyle? I can speak about the evidence that getting a really good sleep pattern is protective, as is exercise and a number of other things. So I'm trying to be broad. I'm trying to be holistic. I'm not going to jump straight into, you need a mood stabilizer. You're going to take tablet regularly, potential for kidney risk, potential for dehydration, and you need a regular blood test. No, let's get to that a bit further down, where we've shown openness to a variety of different treatments. People want to know if there's an option for vitamins. There is some evidence around that. Again, the effect size isn't strong. Possibly the best effect is about vitamin D in the treatment of depression, where there is vitamin D deficiency, which is very, very common. So I'm going to talk about a whole bunch of things and use the medicine as part of that spectrum. I'm going to acknowledge at all times that the client is the expert on what they experience. So I maybe think that if I prescribe this antipsychotic, it will have this effect. That might not be what they experience. They might experience something quite different. So I want to know, how is this affecting you? Are there side effects? Are there benefits? Tell me all about them. I want to know about them. I'm not going to close them down. I want to open up that discussion. And I really want to know, I asked you to take one every day. Is that something you've done, or have you found that you only want to take them once or twice a week? I want that feedback, because if I don't get the feedback, we can't have the discussion. We do know that the relationship with the prescriber, that is whether you trust that prescriber and like them is a key indicator of adherence, and whether the family are on board with the plan is again a key indicator of successful adherence and prevention of relapse. So these are basic principles for me. So concordance is defined in an extreme way. It means that the patient or client simply does not take the treatment exactly as prescribed. So you have failed in concordance if you miss 1 or 2 tablets per week, or if you take a lower dose. So it's quite an extreme definition. And coming from the medical side, that's what we want, because we've been trained to know what we think to be the correct dose and the correct medicine, and this is how you take it to get better. There are problems with the definition, because the first thing is, does the medicine work? I mean, why would someone be concordant if the medicine doesn't work? So we think about schizophrenia. We know that the first or the second antipsychotic will lead to recovery in 1 person in 4. So that's fantastic. And it will keep them well if they stay on the dose of medicine that got them well. The question is, can we have the support systems in place to keep the medicines going that long? Of those that don't recover with schizophrenia, 1 person in 4 will then recover with clozapine, because clozapine is different. Now, if you think of 1 in 4 and 1 in 4, you just about get half of everybody with schizophrenia spectrum disorders in recovery if they will take their first or second antipsychotic or their clozapine. Now, the first or second antipsychotics basically block dopamine. They're specific dopamine blockers. Clozapine blocks everything. So we've got 2 kind of complementary type of medicines there, that really very highly effective medicines. It's often the case that clozapine isn't available, or it's difficult to get access to it because it needs blood tests and occasional ECGs. So is the medicine effective for psychosis? That is a moderately strong effect size. It does work. The music at the start said the drugs don't work. Antipsychotics pretty much do work. They're not as good as antibiotics for infection, but they're right up there with effective treatments. We don't have antibiotics in psychiatry, unfortunately, but it may come at some point. Mood stabilizers, lithium, are right up there with the most effective treatments in psychiatry. So a lot of these drugs do work. What about the half of people they don't work for? Now, there's a problem. So those people they just don't work for, but I mean, we need to be honest about it. If they're not working, they don't work. There will be a bit of placebo benefit with them, but is it worth paying the side effect price for a placebo level benefit? If the drugs don't work, you really need to be getting into psychological treatments, family therapy, because there's every chance you will get a result there. Does the patient understand about the drugs? Do they accept it? Well, that's what I was saying earlier about the importance of a high quality therapeutic discussion about medicines. Because most patients, to be honest, they leave the consulting room having a grasp of something that's been said, but not enough information to make that decision about adherence. Can they get the medicine? I don't know about different states in the US. Certainly lots of bits of the world, there's various medicines that you just can't get access to. Then we'll get that question again, will the family accept and support this medicine? And will the culture accept and support it? So this is just a description of how well the antipsychotic medicines work in preventing relapse. The dose that gets you better keeps you well. Now, that is pretty much true for depression, bipolar, and across schizophrenia. So you see a trial here of antipsychotics against people who are randomized to placebo. And at the 2.5-year point, the group randomized to placebo, only 20% haven't relapsed. 80% of them have relapsed and probably been rehospitalized. Of those taking their antipsychotics, it's only 40% that have relapsed. So not everybody, but that's a strong effect size. These drugs do work for many people. We mentioned about the spectrum of adherence. Now, some people will, well, maybe just take a tablet on a Friday night or a couple of times a week, or maybe they might half their tablets and just take smaller doses. That would be called partial compliance. And unfortunately, the evidence is that the worse your compliance is, the more you space your medicines out in terms of time, the more you relapse. That having been said, there are some long half-life medicines which you do better with, but most of them are shorter half-life. And your brain's confused by it. You know, 1 minute, the dopamine receptor's blocked. The next minute, it's bouncing back to its previous high level of activity. So if someone's in the ward, what predicts their non-adherence after discharge? They're well at the point of discharge. What predicts them becoming ill again, stopping their medicine, and needing to be readmitted? Well, it's the second one down there says that the family is massively important. If the family aren't supportive of that medicine and facilitative of it, that very often leads to non-adherence and relapse. The Poor Therapeutic Alliance is a real biggie, because if the patient doesn't respect and appreciate and have some kind of rapport with their prescribing psychiatrist, it means that relapse is highly likely. That's why these prescribing discussions are so important. Poor insight, as would be expected. If insight hasn't a bit of recovery, that's a big factor. And what we're going to talk about in 2 months' time, substances. Substances are getting involved in the mix of partial compliance, use of cannabis, cocaine, various other substances, leaves your brain seriously confused. So these are the key factors. So over time, we get more and more people relapsing as they come off their medicine. So we really want to do everything we can to ensure adherence. So we're going to do a role play now to try and demonstrate some of these points. And in this, it's going to be myself and Bob who are going to role play me going to my doctor, my family doctor, for a prescription for an antidepressant. I've developed depression. And I come back with my prescription and I'm slightly worried about it. And I'm going to ask Bob if I should be taking this medicine. The GP, I could remember some things about what the doctor told me. I asked him about therapy. He said there was a very long waiting list. So a tablet was really all that was available. He also gave me a funny look and said there'd been some controversy about this tablet. It was called an SSRI, a specific serotonin reuptake inhibitor. But he said I should just get going and take it and see how it goes. So, Bob, are you there somewhere?
I'm here. Yeah. I'd like to hear more about what the doctor said and what's your thinking about the medicine.
Well, Dad, I've come back really quite worried. I was only in for, I don't know, 10 minutes maybe.
Yeah.
He was speaking fast. It was as if he was trying to get me out, He was a nice guy, but he's told me that I should take this tablet, though I really wanted therapy. Because I'm not sure about tablets. In our family, no one's really on tablets, are they?
Well, it's true. We've tried to avoid taking medicines when we don't need them. But what did the doctor say about the reasons to take the tablet?
He said depression's quite dangerous because you can get terribly low in mood. You can stop eating.
Yeah.
You can even get suicidal. So he said the tablet, if you wait a couple of weeks, will start to lift my mood and I'll start to eat again. And I'll start to feel more positive.
Doug, that sounds important. Did you feel comfortable with the doctor? Did you feel like you could trust what he was saying?
Oh, I thought he was a really nice man. I thought he seemed to me to be an expert. He seemed to know what he was talking about.
Yeah. Did you come away with some questions that you feel still need to be answered?
Well, he gave me a funny look.
Mm.
And he said, he says, there's been a bit of a controversy about this type of tablet recently, but you shouldn't worry about it. You should just take the tablet one a day and we'll see how you go.
And how did you feel about that after leaving his office?
Well, I wanted to know what the controversy was.
The
game, garbage can is yours.
Oh, yeah, you can leave.
Someone needs to mute themselves. Okay. So, yeah, after you left the office, you had some questions.
Yeah, I wanted to know about this controversy.
Yeah.
I've got to be honest, Dad, I came home and I did look it up.
Yeah.
And what it said was, there are some people saying that this serotonin stuff is nothing to do with depression at all. And the American Psychiatric Association, they've come out and said people must stay on these tablets and that it is peripherally involved in depression. They're kind of accepting it's a bit of a placebo, Dad,
Okay, it's a bit confusing. It sounds like you've got some questions, and I'm just guessing you're a bit anxious about taking the medicine with those questions.
Well, I've not filled the script yet. I've not gone into it.
Yeah.
I'm still thinking about it.
When do you see the doctor the next time?
2 weeks' time.
Yeah. Doug, I'm just wondering if you'd be willing to get started on the tablet and we could maybe put together some of your questions and some of your worries and maybe kind of write down things you want to ask the doctor in your next appointment. Do you think that would be okay, just to get you started?
Well, I did kind of trust the guy. So, yeah, I think this is a low dose I'm on. He said they're starting a low dose.
Mm-hmm.
And like, will you kind of keep an eye on it? I'm really not sure about it.
Maybe
So-
we can sort of check, every day after you've started. How are you feeling? Is there any differences? We know it doesn't have effect right away.
You
But
once kept a diary about grandma's health.
Yes, I think
Could
that's
we
a
do
great idea. Yeah,
a little diary to see how, in case any side effects come on,
yes.
or I don't, or get worse or whatever? That
We
would be
could,
good.
yeah, we could do that, and then you could bring that into the doctor, right? Just as to tell him how things are going, and if you have some questions.
Okay. I'm reluctant.
Hmm.
I'm going to go and get the prescription. I'm going to take one when I come back, and we'll play it day by day. How about that?
That's great, and I'll make sure we jot down any concerns you've got where you want questions answered in the meantime. Okay.
And you'll back me up, Dad. And if it's not going good, you'll agree with me that I can stop it.
I'll kind of do my best to support you and get all your questions answered. Yes.
Okay.
Okay.
So it is a very, very difficult thing for families, isn't it? When you spin out of that kind of consultation, and I just wonder how many patients go home to their families and that kind of discussion happens. So I wonder if there's any questions or comments at this point in the webinar.
Yeah. Well, I'd like to get any specific questions about talking about medicine in this way. There's a couple general questions. And one is about this, when you're on a very complicated regimen of medicines, there's several medicines and an injection that have to be taken daily. How do you address just fatigue from keeping on the schedule and keeping track of it?
I think it's very fatiguing cognitively and physically, because if you are on a polypharmacy regime, you've got lots of different tablets. You've got to make sure they're not interacting with each other. You've got to make sure you're taking them at the right time. That probably means a pill box or a diary or something like that. And there's the cognitive impact of the illness that you have in the first place. So take people with depression, they're not concentrating well. And if you've got depression plus diabetes, you've got a whole bunch of stuff to take. And it's very difficult to keep your mind on that. If you've got schizophrenia, you've perhaps got problems with concentration and memory. So you really could do with a family helping you out with that way. There's a thing called cognitive adaptation therapy, which Don Veligan invented. And this is kind of reminders and signs and little alarms that go off. And it was Don's team that came up with a pill box that plays the music. So things like that can reduce the load of it. Because if you've got a thing up in your fridge door saying, this is the regime, you take this pill at 9, the next one at 12, there's an injection at 6, it's all up there and you can tick it off as you go through the day. That reduces your cognitive load because it's quite a tiring job to take all those medicines.
Right. So there's a second question, Doug. It's a bit more general, but it's about when someone's been on a antipsychotic for a long time, in this case, more than 10 years,
Yeah.
and on a mood stabilizer, and they've been quite stable, is it possible to begin to titrate down the antipsychotic? And what's the risk of relapse if you begin to do that?
Well, that's a really important question. And I think part of the answer is what happened before. So over 10 years of stability, recovery, and health, which is fantastic. But of course, there are side effects. From lithium can have side effects on your kidney function. The antipsychotics all have their own different side effects. So if you've been stable and you haven't been relapsing repeatedly before, I would be tempted to follow the NICE guideline, which is to go for a gradual reduction in one of the tablets, one of the medicines, under supervision. And it would be a very, very slow reduction. And what we normally do here is we plug in a bit of therapy. Because very often as you're coming off an antipsychotic or a mood stabilizer, you might start to get slightly anxious or paranoid, or your mood might start to swing a little bit, swing up or swing down. And the therapist can then help you use CBT to try and deal with those symptoms. We've had a lot of success doing that. And then you can get the dose down to a level where there's less side effects, or you might even be able to come off. But if you've had a previous pattern of lots of relapses, I wouldn't be attempting that. So it depends on the individual case. But the NICE guideline says, if you're in recovery for 2 years from a psychotic illness, get your prescriber to help you think about a gradual reduction. How often that happens, I don't know.
Fantastic. Is there time for one more question, do you think?
Certainly, yeah.
Okay, yes, this is about your experience, and it's really about the training of, I suppose, providers, psychiatrists, therapists, psychologists, as well as family members in kind of medicine adherence compliance. And I'm just trying to, yeah. How well are providers trained in this area, I guess, is one question.
I would say medics are very well trained in diagnosis, less so in formulation, but Adolf Meyer was the biopsychosocial formulation guy, so we do a bit of that. So they're good at getting the diagnosis right, usually. They're then good at knowing the correct class of medication. But I would always argue that we are not well trained in what we're doing today. That is how to prescribe, how to have that adherence conversation, which is collaborative and optimizes the prospects of adherence. I think too often we sit there as the expert and we kind of expect people to pick up the bits of bread falling from our table, you know.
Okay, and then just
take it.
Just 2 requests, just to keep in mind. People are interested in that musical pillbox, and maybe we can find put a link to it in the chat or put it on our website. That's kind of one thing. And there was something. Oh, the second part of. Hold on a second. The second part of the question, yeah, is maybe we can also link to some information about the value of families in medicine adherence. It would be great if we could link to some articles or some information that families, I suppose, could bring to their providers.
I think that's very, very helpful. So thinking about the musical pillbox, the original pillbox just played a bit of music and it was good. But then came out a pillbox that you could program to a bit of music you wanted it to play. For example, get it to play The Drugs Don't Work. I mean, that introduces humor into the whole thing, doesn't it? So that when it plays The Drugs Don't Work, yeah, that's the time I go and take my drug. So the pillbox plays a programmable tune. The box plays a programmable tune was even more effective. Strange. This is Don Veligan's work on cognitive adaptation.
Yeah.
But we shall get those links.
Okay, great. I think we'll probably have to move on. There's a few more questions we'll try to come back to in the general Q&A.
Okay, sounds good. So we mentioned about automatic thoughts and images. And I think this is very powerful because when I thought about those 2 inhalers I'd been given, I had really quite surprising automatic thoughts about them. I thought one of them just didn't work. Where did that come from? It's not rational. And we very often, when faced with a medicine, the thoughts that come to us are from family rules. Oh, we don't take these. Or it's something from our own health belief history. For example, I don't think I deserve medicines that are expensive. That's kind of depressive view. But there's all kind of thoughts people have. Now, a great thing that families can do is to ask their loved one, see, when you think about that medicine, what goes through your mind? Is there a thought there? Because when that nurse asked me, I just told her and realized it was a nonsense thought. And that really helped me turn it around. So if we can catch, because these thoughts are driving non-adherence with medicines, and they're very often not sensible. Sometimes it's a picture in the mind, or it might be a picture of getting an injection in your arm or in the buttock. It might be a stigmatizing sort of feeling image about an injection sort of treatment. And it might be that link into stigma or shame that is actually driving the desire not to have the treatment. And of course, there's things you can do about that. For example, the nurse that's given you that injection, she must have seen hundreds of men's buttocks over the last year. I'm sure she's not worried about seeing yours. We can introduce a bit of humor because there's that shame side, which sometimes is very, very important. That nurse isn't bothered. She's really not upset about it. So we want to catch them, and they aren't processed. So when we verbalize them, they become processed. So when Doug tells Bob about what he's thinking about the medicines, about his feelings about it, he's verbalizing something that was only inside his own head. So families can ask these questions. It's important to ask in the right way because people might feel that they're being criticized, or they might take it in a slightly negative way. It all depends. It depends how it's asked. So, is there a thought going through the mind, or is there a picture in your head when you think about your injection or your syrup or going to the doctors? Let's try and catch them. They might be quite easy to change. I now take the brown inhaler. I don't take the blue. It's all changed. I'm the better for it. So the best time to catch these thoughts is when someone breaks off conversation or contact with you. Someone suddenly looks away. We ask them, you looked away there. I just wondered what was going through your mind. And you're going to catch a thought. And if they're looking away, it might be a thought about shame or anxiety, but we can catch that thought and then we can talk through the thought and process it. Obviously, what would have been good to have asked that doctor that Doug saw was, you looked at me funny there. I wonder what was going through your mind at that point. Because that would have been a very good question to have asked at that point. Catch them if we can and ask about them, verbalize them. If there's a picture, let's talk it through. If it's an image, we talk it through. And these can be real benefits in terms of improving adherence. Very simple things to do. But as is often the case in the family setting, simple things can have big benefits in terms of recovery and relapse prevention. Okay, so we're going to talk a bit about health beliefs, family rules, and culture. Because we're all embedded in our families, and families have lots of interesting beliefs and systems they work through. And we've got our own history of things that we've dealt with in relation to health, doctors, pets, family and friends, etc. And we've all got our culture. So the health belief model is a good approach for families to use to help a loved one who is struggling with adherence with medical treatment. The first thing is to share the power. You just want to know what they're going through. We're not always pushing on with the coercion side of it, which is tempting to do. Look, you know you become unwell if you don't take your medicine. Why don't you take it tonight? Take it every night from now on. Come on, let's just take it. It's encouraging, but the evidence is that doesn't really work very well. It depends how it's done. We need to tune into why they're struggling to take it. Are they forgetting it? Very many people are so preoccupied with their delusions, they just forget. So forgetting it. For some people, if you go high enough and your mood goes up and you become hypomanic, you don't believe you need it. You believe you're superpowered and medicine's just irrelevant. So it depends where you're coming from in terms of your own mental state as to whether you think you need this medicine or the reasons you're not taking it. Sometimes people who are paranoid won't take the medicine because they think it will sedate them and they will then be attacked by whoever it is they think is persecuting them. So it makes sense for them to take a small dose or not at all. So we need to find out what their view is of the medicine and why they're taking it or not taking it. What they perceive is the crucial element. That discussion needs to be opened up. What are the key factors within that discussion? There could be a number of different factors, but what is the big one that they're not taking it for? Is it a side effect that they don't want? Or is it something to do with a delusion or a voice or whatever? Certainly clear that for anyone, whether they eventually do decide to take the medicine or not, is a balancing act by a number of factors. So our minds are thinking this through. There's some reasons for taking it. Mum wants me to take it. She'll be happier if I take it. Does give me a sleep. On the other hand, it's got side effects. It gives me restless legs and it makes me feel numb mentally. How do you balance that out? In that person's mind, they will, maybe not consciously, but the decision will come as to which way the scales are going to tilt. Do they tilt towards, no, we're going to miss it, we're just going to leave it? Or do they tilt towards, let's keep mum happy and let's stay on it despite the side effects? That's a balancing act. So there's the scales. And for all of us, we're on these scales somewhere. For every medicine, every treatment we have to have, every time we're offered an operation, surgery, am I going to take it? Am I going to go for the operation or am I not? What are the pros and cons? These need to be spelled out. So in the health belief model, we're going to talk through with our loved one, what kind of benefits do you think you get from this medicine? Or what might you get? And what is the downside? Because we need to work out these scales. And in people who are not taking their medication, they've normally put an awful lot of focus on the side of the scales, which is up here, which is about side effects, all the negative factors, stigma, all the things that might go on that scale. So in this example here, the person thinks that the effectiveness of the medicine outweighs the side effects, they are going to probably stick with it with a bit of encouragement, and they might not relapse, which we saw in an earlier slide. But those people that are relapsing, they are normally ignoring the potential benefits, and they're really quite focused on side effects. I've gained a stone in this medicine. I'm not taking it anymore. Okay, they've been out of hospital for 2 years. They need to, it's worthwhile pointing that out. So a family member can point this out to a loved one. They can look at their own scales. They can ask them what they put in the different bits of the scale here. What's the downside of this medication? I just want to know your experience. You're an expert in this medicine because you take it. Tell me what the downside is. And look at the other side of it. What are the benefits of this medication? And as you work through this discussion, the scales can change and they can tip towards better adherence. But unfortunately, they might tip the other way. That's a possibility too. But as you're normally doing this with somebody who isn't taking their medicine well, it's probably going to tip towards taking the medicine better if we do this health belief exercise. Now, this does seem to be an effective intervention for families. So if you think about the things that tip the scales towards adherence, these are the things that people who aren't taking their medicine tend to ignore or not give much credit to. Is it giving you some symptom relief? When you take that medicine at night time, do you feel a bit more relaxed the next day? Do you get a better night's sleep? Do you feel maybe the edge has come off the paranoia or the voices? If the person says, yes, that's true, when you put it that way, that is true, that's going towards adherence. So we need to keep encouraging that point, but we can only do that if they agree that that is true. Do you think, I mean, you've been out of hospital now for 2 years now, the medicine, do you believe it is acting to prevent you going back into hospital, to prevent any relapse? Because if they can endorse that, that's another big factor. So for some people, that is the only reason they take the medicine. They don't want to go back to hospital, and that's the reason they take it. But it's worthwhile, as a family member, flagging that up and being clear about it. If people think that their medication helps them, go to the drop-in centre, the recovery college, go to that voice hearing class, go to the woodwork class, get back to college a couple of days a week. That's their life goals. If the medicine's acknowledged to help those goals, that's very powerfully supporting adherence. So these are the kind of things we might discuss with a loved one. If one of their goals is to meet a lifetime partner and get settled down with a girlfriend or boyfriend, whatever, would the medicine help that by improving the concentration, maybe improving their ability to cope in a social setting? If that's endorsed, that's positive. If the belief is the medicine's got me this far, I'll just keep it going until such time as I'm told to reduce, that is a factor. If the person has sealed over, that is, they think their bipolar mania is something that happened 3 or 4 years ago and it's in the past and it's gone, then they might want to come off their lithium or mood stabilizer. And that might not be the best thing. So bipolar is best probably viewed as a tendency to these kind of mood swings, which probably needs ongoing mood stabilizers. The question is, can the dose be reduced a bit? And that could be discussed. Now, the things on the other side of this equation are the things that people say when they're not taking their medicine. It's not helping me at all. I don't care if I go back into hospital. Medicines have got nothing to do with it. The medicine stops me from getting out to the recovery college or meeting a partner. No thanks, I don't have bipolar, thanks very much. That I went high for a while, that's true, but I don't have it anymore. So it's a balancing act in the health belief model, and families can talk through these things. For me, though, families, in having this collaborative discussion, are probably going to be wanting to help the loved one to realize that they aren't acknowledging some of these factors on the left side here that promote adherence, good health, and prevent relapse. So what about key personal factors? There are reasons people don't take medicines which are just to do with them. Some people have a core belief that they aren't lovable, that they are people that don't deserve treatment, they don't deserve affection. And of course, people with that belief very often end up in traumatic relationships because they don't think they deserve a good relationship. So again, you would catch this in the automatic thoughts that they don't think they deserve the medicine. Maybe it's for other people, or that they're perhaps dirty or undeserving in some way. And you have people who say, I've got to be in control of my life. I can't be taking that stuff. I need to be in control. I've got stuff to do. Now, that's a kind of anxious non-adherence. And it actually might be the case that the medicines do give them control, and they don't have control when they don't take the medicine. But the thing to do about control is to flag it up if that's an issue. And this is one that is discussed in a video clip later, where someone wants to be in control and they stay in control by having drug holidays. They go for a week without their medicine just to prove that they are in control. And that's kind of understandable as long as it doesn't lead to relapse. Approval. Lots of people want to hide their medicine. They don't want anyone to realize that they are on an antidepressant or a drug for anxiety or olanzapine or something. They're just embarrassed about it. And here it seems important to talk more about it, to read stories of recovery, and to listen to people who talk about the benefit of these kind of tablets, and to try and reduce this feeling that others will disapprove of them if they find out that they're on a mood stabilizer, say. It's got to be something they can say to some people, I'm on a mood stabilizer and it's doing a great job for me. I must achieve my goals, and this medicine is stopping me from achieving my goals. Well, again, the question is, if the medicine's controlling your voices, and if you can concentrate better, is it not possible that this medicine is helping you achieve your goals? So we all have key personal beliefs which link into whether or not we take medicines. As I said at the start, this is a very complex subject, isn't it? And each one of us are an example of it, because we're probably all in some kind of medicine, or we've had medicine at some point. So all of this stuff applies to everybody. It's the human condition. Family beliefs are interesting because these are embedded in families and they're often not talked about very much. It's an understanding within the family. We don't really use medicines. We like to stay away from doctors. I would never go near a surgeon. Oh, no. So you get these kind of ideas about what the right type of treatments are. The Prince of Wales, who is now King Charles, he believes in homeopathy. That's what he believes in. He believes that is, if you can manage it, that is the best way to go. But he will endorse more classical medical and surgical treatment in severe situations. And this is the case across almost all religious faiths. If the situation is severe enough, they will agree that you can take that particular type of treatment. But what a family can do is work out, what is our family rule? We tend to like exercise. Yeah, exercise is a big one in our family. Is that going to work? Because if not, let's give them permission to have this medicine and do something different. So maybe families can give permission for the family rule to be broken. Some families think medicines are lifesavers. There might be somebody in the family who's made a fabulous recovery or whose life has been saved by an intervention. And there the family rule is very different. It's like, you're getting a medicine, great, take it, son. This is good news, you're going to get better now. Think about the person diagnosed with ADHD, adult ADHD. They've been struggling their whole life with attention and disengagement, struggling to manage their workload. And at last they get their diagnosis. And they're going to get medicine for their ADHD. It could be a lifesaver. They go back to their family. ADHD, nah. I don't think so. I don't think we believe in ADHD, you know, because families have got their own beliefs about ADHD, schizophrenia, about everything really. Everything has its a resonance within the family. So the family could be super supportive and say, that's great, thank goodness you're getting your medicine. We'll look out for side effects. It could transform your life. They could give that perspective on the taking of this stimulant medication. Or it could be a fairly negative reception that the stimulant medication gets. It's up to us. It's our choice. Then you get family examples. Look at your cousin John. They spotted his diabetes in time. He was in a coma. He got insulin, and he has had a fabulous life. He swears by medical treatment. He swears by insulin. He swears by the diabetes service. He is an advocate. He has founded his own support group. That's a great family example. Then if you're in a family like that with John there, you're allowed to be ill. You're allowed to tell people you're ill and you're going to be having a treatment. And you're going to expect that people will support you because John has showed the example. Then they get key family events. We had a dog called Bobby that died because the vet gave him digoxin and he gave him too much. Now, that gives you a very negative perspective, doesn't it? Because the dog was like, I don't know, 4 or something. And the vet said he's got a heart rhythm problem. We'll give him this. And he died the next day. He gave him too much. That's a very negative family example, isn't it? We've all got them in our family. So it depends on what we do with that. It can dwell in your mind and put you off going to the vet again. Or you can say, okay, that was maybe an inexperienced vet. Maybe it was the wrong treatment, but we're going to try again because there was something wrong with his heart. And that's fair comment. So there's key events happen in families which flavor our views of medical and veterinary treatment. cultural beliefs. Well, some people think syrups are the way to go. So I've got a big list of all the different antipsychotics and mood stabilizers. I've got the ones that you can get in a syrup, the ones that you can be dissolved, the ones that come as injections. And I'll say to my patient, this is the list of the medicines that help with voices, for example, or can help with voices. These are the different preparations we have, and these are the main side effect that you might get. So if you're in agreement with me, you want to try one of these medicines, because we tried the herbal tea, and to be honest, we found out it didn't work. So if you want to try one of these, would you like to choose whether you want a syrup, a capsule, and tell me which side effect you absolutely don't want, and we'll go for one of the other ones. Now here we have collaborative prescribing, where the patient is given choice, and that choice is so powerful because you've actually partly chosen this medicine. When Doug went to the family doctor, he didn't get a choice. You get what the expert chose for him. When you get a choice, you're much more motivated to take the medicine, and you're much more motivated to interact with the prescriber. So that list of all these medicines, side effects, preparations is very useful. There's a Spanish idea that if you're going to get a medicine, it has to be injected. I don't know if this is kind of in the Hispanic community, but all the best medicines are apparently injected. So for there, I mean, it would seem sensible to cut to a depot injection, and you'll get much less kickback on that. We have problems in a lot of the faith groups in terms of what's in the medicines. I mentioned this. So very often the capsules have gelatin in it, or they have stearic acid in it. And these are not halal and they're not kosher. So if we're unsure, we should seek advice. Obviously, we go to the medicines compendium. Is this appropriate for someone who's Muslim? If it's not very clear, I should probably go find an imam and find out, is this medicine okay? Because all that effort, I mean, it might just be an email or a phone call or something, is you engaging with a culture. Rather than just a 10-minute appointment, you're actually engaging with the things this person believes in. And we know in the Muslim community, adherence is extremely poor with these kind of medicines. And it's partly because the medicines aren't prepared in the way that they find acceptable. So we need to be smart about that. Some people still think diets can sort the problem, the ketogenic or the gluten-free diets. Now, gluten-free diets are quite difficult, and because they're probably easier now than they used to be, but I would be happy to give that a try if someone really believed in it, as long as it didn't go on for too long and they were actually deteriorating. So diets, if someone's really wanting to do that, and if it's safe, I would help them give it a try on the grounds that we might cut to something that's evidence-based if it doesn't seem to be working. But this depends on severity. Okay, I don't know if there's any questions, Bob, about any of that stuff, or where we want to see this, what I think is a collaborative medication discussion.
I'm going to recommend we watch the video first, and then any specific questions we can take after the video.
That's good. Well, just let me know, Bob, if this sound, for some reason, isn't working.
Give you a thumbs up.
Eve, it's nice to see you again. Now, we had some homework we were doing over the last week. Can you remind me what you were doing?
You asked me to sort of just monitor when I took my medication and when I didn't.
Mm-hmm. And we we had a look at your diary, and roughly how many did you take? You were meant to take over the week 7 tablets, 1 each day. How many did you manage to take?
Well, I didn't really do the homework. Well, I did, but I'll be honest, I didn't really put the honest information in.
Okay. Because you've written down here that you actually took them all.
I know, and I feel a bit guilty, but
Okay.
that I did that. But I just feel a bit anxious now, and I don't want to lie to you, really.
Well, I think all we want to know in terms of medicine is what's the truth of it. Because if we know the truth, then we can come to a joint understanding about whether this is a good medicine, whether you think it works for you. So I'm not bothered that you've tried to show me a good score.
No, but I can't sit here and give you that honestly, because I just would feel really bad that I've not been truthful, really.
So have you taken 1 or 2, or have you not taken any at all?
Well, I've taken some. I think towards the beginning of the week. I mean, I have every intention of taking them. I don't really know why. I don't really know what goes wrong, to be honest.
Well, I think it is a normal thing for anyone who's on a course of tablets to not take them all. So
Really?
I think that's really very, very common. Certainly when I had the antibiotics, I never finished the course. So us doctors are hopeless at taking the tablets sometimes. So I think that's just kind of normal.
I thought you'd be really cross. I feel a bit of an idiot, to be honest, really embarrassed, especially because I've sort of put that I've taken it down and I didn't.
Well, you were wanting to show me that you were really trying. I suspect that's why you put it
Yeah,
down.
absolutely, because I don't want you to think that I'm not bothered about this.
So what we might want to try and achieve as a target for this session is to increase the number of tablets taken over the week from 1 or 2 up to 3 or 4. I mean, would that be something we could work towards, do you think?
I want to. I would like to take more. Like I said, I start out by, each day I think, right, I'm going to make sure I take all my medication, and I just end up not doing.
And what's going through your mind just now when you're thinking about not taking the medicine?
I'm trying to figure out why, because like I said, I have intentions to, but I think sometimes there's a part of me that it's easier when the voices are really troubling me. It's easier to take it, but I have periods sometimes when it doesn't, when it feels a bit better, and then I almost think, well, what's the point? And I don't want to have to take this forever.
Okay, so there's ideas about when I'm really distressed, that's when I take it. Otherwise, I would kind of rather not take it all the time. And I definitely don't want to take it lifelong. These are the thoughts that go through your mind.
Yeah, and it's not like I set out to, to think, oh, I'm not going to take them at the moment. I kind of want to, but then I just forget, if that makes sense.
Okay, or it's not important enough for you to complete the action.
Yeah, I mean, I'll go to bed and I think, oh God, I didn't take my medication. And then I think, oh, it's downstairs, and I just think, oh, I really resent having to take it. I hate having to take medication.
I mean, I suppose the other side of that is at some point in their life, everybody is on a course of medication.
I've been on this for so long, and there's a part of me that I don't want to have to be taking medication.
Well, what the NICE guideline says about these medicines is if you can get better by taking them really regularly, and if you can stay well for a couple of years, you can start to come off. But if you take the medicine hit and miss all the time, then the medicine never really gets a chance to work properly. And so you maybe never get as good a recovery as you might get.
It's funny because as you say, if I take it, then I could come off at some point.
Mm.
That makes me feel so much better. And I can almost see, if I could see a day where I wouldn't have to take it anymore, I think my motivation to do it right now would go up. And sometimes I wonder whether I forget, not intentionally, but because I'm actually stressed about taking it.
Mm-hmm.
So I just forget to, because I don't want to have to think about it.
So you're distressed about the thought of having to be on medicine.
Yeah.
And what I'm hearing you say is that's mostly about being stuck on it forever, and you're angry about that. So we were speaking before about rational responses, and a rational response, which you gave us a minute ago, Eve, was there will come a day
Yeah, but
when
will
I
there?
probably can start to reduce. Because that gave you a lovely feeling that.
Yeah, but I don't quite believe that.
Okay. I mean, that is what the big, nice panel said. We don't want people to be on medicine forever.
But can you promise me that one day there will be a time when I don't have to take this anymore?
I can't promise that. What we need to do is to see the benefits. Now, you've told me when you do take a tablet and the voices are bad, they do seem to work. And they seem to work quite quickly. Now, that might put you in the good prognosis group, for people that have really disabling voices. 1 in 4 has a really good result to medicines.
Well, to be honest, I don't really know if it does work that well or not. I've never really, I just see the point of taking them when things feel bad, because, you said that it would make it better. So I do take it then, but I don't really know whether they help or not.
Would that be something you would like to find out? Whether they actually deliver a real result for you?
Well, it would be useful to know whether there is any point in taking them, or whether this, I'm not really sure that this medication that I'm on at the moment is that great.
Okay, how could we find out if it worked?
I don't really know whether the voices, I mean, like I said, I have periods where they're not so bad, but I don't know whether that's just happening by chance or whether that is the medication.
One way of finding out would be to either have a week with no medicine at all, and we'll score the voices out of 10, or we have a week with a tablet every day, and we'll score the voices out of 10, and we'll see how these weeks compare.
Yeah, I would do that.
That would be scientific, wouldn't it?
At least I'd know.
Then you'd know, because nobody wants to take a tablet that you don't really know whether it works or not.
Well, exactly. And also, if I knew that there would be a day, like I said, where I wouldn't have to take these anymore, then I'd feel more motivated to take it.
So on one side of the scales towards taking the medicine seems to be the fact that it does produce some benefit on the voices when you do have one. Is there anything else in favour of taking it? Do they give you a sleep when you take one? Because it's a nighttime tablet.
Well, again, I don't really know, to be honest. I don't know if I've taken it regularly enough to really know that.
But getting a sleep would be nice, wouldn't it?
That would be much better if I could just sleep more regularly. But I don't want to feel so tired in the mornings, because for quite a while, getting up is real effort.
So this is looking at the other side of the scales, the other side of the equation, as to whether you take a tablet or not. On the one hand, is it working? Is it controlling voices? Is it reducing stress? On the other side, what's the side effects like? What's the downside?
One of the things that I really get, I don't know if anybody else gets this, is because the tablets I take, they're like sort of in this plastic coated thing. And I just feel it gets really stuck in my throat, and it's a burning sensation.
Oh, yeah.
So sometimes, especially at night, I don't want to take it, because if it gets stuck it feels as though it's stuck in my throat. And that burning sensation, it keeps me awake, or I wake up throughout the night. It's really unpleasant. Is that something you've heard of before?
I've heard of that. Some people do have that effect.
Why does that happen?
And it's just the form of the medicine. Some people, the capsule breaks down quite quickly and it causes reflux.
Right.
Now, what you can do to get over that is to give it in a different form, in a tablet form, or in a liquid.
Tablet form then?
We can change the form. Absolutely.
And then the only thing is I genuinely just forget sometimes. It's quite a hassle.
Yeah.
You've got to remember to have water or have them with you. And I'm not always at my house. I sometimes go to my parents, or I'm in different places.
Traveling about, yeah.
And it's just really hard to remember because they come in these big packs and you can't just carry them around.
Well, one thing is a pill box, isn't it? Where you have one of these little plastic slips and you put the pill in for each day. And maybe you then have the pill box beside something you do every day. Presumably you'll do your teeth at the end of the day, will you? Brush your teeth? Maybe the pill box could sit beside the toothpaste. And then you'd see it and you'd remember, I've got to take that pill, and take the pill at that point. So that's something. Also, are there any kind of rules in your family about tablets? Some families hate pills and tablets. Other families really like them.
Well, in my family, nobody's ever really agreed with taking medication.
I see.
People don't even really take headache tablets. So
So that makes it difficult for you if you're traveling about your relatives.
And I don't really want them to see me taking tablets. And it's the thing about people say, oh, what are you having to take that for? And also, some of them don't believe in drugs. They're quite into alternative medicine. And they'll say things like, oh, well, if you did this, that, and the other, you could get off that. And I just feel a bit of a...
That's tricky, isn't it?
Well, it makes me feel a bit of a failure as well, to be honest.
Yeah, I can see that if that's the family rule. And do we know where that family rule came from? Was it something that happened, or?
Well, they're just all really into sort of healthy lifestyle and alternative medicine, just being healthy. And I feel as though with them saying, oh, if you did this, that, and the other, and you took this out of your life and you lived like this, you wouldn't be needing to be on all that medication, as though it's my fault.
Well, they do have a bit of a point. Healthy lifestyle's a good thing, isn't it? But in terms of voices, there's almost no evidence for herbal remedies producing benefit. So I think they might have that bit of the equation wrong. Another way you could have your medicines via injection, so you wouldn't have to carry tablets. I mean, would you like to have an injection once a month?
I'm not really someone who likes injections, to be honest.
Okay.
But, well, would it have any different side effects to taking the tablet?
Well, we can give the same medicine as injection, or we could give a different type of injection. If you told me which side effect you didn't want, then I could probably find the right injection for you.
It's not really appealing, to be honest.
Okay. No, it's just something that's possible. Okay. Our target was to try and get up to 3 to 4 tablets in the next week and just do a totally honest record. Do you think we're going to manage it?
Well, I'm willing to try.
So can you kind of summarize for me the kind of key things you're going to try in the next week?
Well, one of the things was really keeping the diary and seeing if the medication actually does do anything. I would find that really useful. You said you'd give me a tablet form, which would be a lot easier. So I'm not getting that feeling of it being stuck in my throat. What was the other thing they said?
Well, the pill box we can do right now.
Yeah, that would be good.
And the other thing we had was a rational response. You're going to say to yourself, there may come a time when I don't need this tablet any longer.
Yeah, if I just knew how long I had to take it for before I could start to come off, that would feel...
Well, they've said if you're well for 2 years, you can start reducing.
Right. It seems like such a long time, but it's better than thinking about being on them forever.
So this week, are you going to try and take one every night then? And we'll see how we do with it.
Yeah.
Is there anything I've said you didn't understand or is upsetting or anything like that?
No, not really.
Well, let's see how we get on.
Thank you.
Okay. Okay, Eve, it's nice. So that video kind of summarized a lot of the elements we've discussed today. And I think I'm showing that as a kind of what you can do in just under 15 minutes. The normal prescribing interview is 15 minutes. And look at the ground that myself and Eve covered in that 15 minutes. We're able to collaborate together. We found a goal together. She was able to tell me all about her concerns about the medication. Some of them I could deal with, some of them I couldn't. We sorted out the form of the medication. We come up with a plan to take it for a week and see if it really worked or not. And we were going to have a review at that point in time. So that kind of prescribing interview is the kind, I think, which delivers much improved adherence. And it was very different to the interview that Doug had and went back to his father, Bob, to say, I've been in for about 5 minutes or so, and he's told me there's a controversy, and Doug didn't have a chance really to voice his concerns or have the depth of that kind of interview. So families and prescribers is an interesting subject. I don't know how much families are allowed to come along to these sessions. I don't know whether prescribers encourage families to come along. I'm certainly very happy for family members to come along if the client wants them to come along. I think that's useful. It's good if they can exchange information about things like family rules and things that the prescriber probably won't know. You get prescribers that are abrupt and dominating, and you get prescribers that are collaborative, reflective, and exploratory. Now, I'd like to think what I was demonstrating in the video was the latter type, but I know lots of prescribers you meet will say, I'm the expert, I'm on this side of the table, you're the patient and you're on that side of the table. This is what you need, and you should go and take it. And that interview can be that brief, or in those kind of words. So we want to, just like a good GP, a good psychiatrist, or a good psychologist are worth their weight in gold, and it's worthwhile trying to find one that can deliver that kind of interpersonal style. If the concordance subject is up for negotiation, you could all be involved in the plan. Families can explain family and cultural rules to a prescriber. Or you might use positive stories of medical treatment. And this is another dog that I had, Rocco, and he was a great big English setter, and he had terrible ulcerative colitis from the day he was born, but controlled with steroids, and then he had a very low dose steroid for his whole life. He had a great life, and he had no side effects with this low dose steroid. So there are really positive stories of things being done well, and we should actually keep trying to remember them to our loved ones. Think about your relative, so-and-so, how well they did with the treatment that they got. So this is just a very brief bit of research. There's not much research in what you've heard today. This is just about the only study. Now, this is the CBT, the cognitive behavioral therapy techniques I've described today for adherence. So it's the CBT adherence intervention. And these were all people with a psychosis. And we ended up being able to have 7 and 9 clients who we could randomize to receive the adherence CBT, the kind of talking you've heard about, or treatment as usual. The downside of this study was that they had to have blood tests so that we could prove whether or not they were taking their medicine, which put a lot of people off the study, to be honest. But very interesting because it's difficult to prove adherence. You can only really prove it by doing a blood test and saying, there it is, there is antipsychotic in the blood test at a decent level. So those people agreed to that, people with psychosis. And the blue line here are the people who had the kind of talking that I've described today. They had a regular weekly session with somebody doing that type of interview. You saw it in the video. I've described the elements of talking about medicine earlier on. And the control group and the poor souls got randomized to have the blood test done, but they didn't get the intervention. And as you can see, an awful lot of them were not adherent. So their adherence is down to about 15%. Now, this is a massive result. This shows that the way that you talk about medicines is extremely important in determining the taking of the medicines. And we've seen earlier, if you don't take enough of the medicine, relapse and rehospitalization in schizophrenia and in bipolar disorder is almost certain, because these drugs do work, unlike what was the music that we played at the start. So again, what were the kind of key things involved when you look at the rating of medication influences? So for the 1 month point, if you remember the health belief model, this intervention was using that. And if people came to realize there was a benefit with these medicine and it could keep them out of hospital, that was very powerfully predictive of them doing well. If they had that good relationship with the psychiatrist, the prescriber, that was very powerful. The family, massively important. Now, some of them were feeling coerced, and that also correlated with doing well at the 1 month point. But what you can see with all these negative scores there is that they're getting really anxious if they feel coerced. And if people feel forced to take their medicine, they will stop and they will relapse. So that fear doesn't work. Fear of rehospitalization, that was the only fear that did last. So the big results here for that side of the scale is seeing a benefit with the medicine, feeling it'll keep you out of hospital, having that relationship with the clinician, and that being mirrored by a positive, supportive relationship by the family. So we've just about got to the end of the content of the webinar here. It must be said that poor compliance with almost all medicine goes across the board, but antipsychotics is particularly low. Mood stabilizers, massively problematic, and also antidepressants. I think we saw Doug pretty unsure if he was going to take his. So this is a major problem in mental health. Now, a lot of the money in mental health is tied up with hospitalization costs. And the biggest cause of hospitalization is poor adherence with medicine. So we could save a fortune, which we could pump into family therapy, a whole group of psychotherapies, different types of rehabilitation, if we could stop this repeated treadmill of relapse. So that I think this is actually a very important subject. There's a number of CBT techniques I've described today: catching automatic thoughts, processing them, using the health belief models, a whole bunch of things. Hopefully something there you might be able to use. If there are health beliefs that you could work on, that would be good. If there are family examples of really successful treatments, that's useful. Obviously, if there's any negative family rules. That would be really useful to try and switch them towards a more positive approach to treatment. And the techniques described here, as the questioner said, aren't being taught enough in medical school, psychiatric training, psychiatric nurse training, pharmacy training. I mean, this goes across the board. This should be available to so many mental health professionals. And it's difficult to change training. We're starting to get some of these things in there. But I certainly think the ideas described, families can use them on a day-to-day basis at home. And as long as you don't try and do too much, just try and do one thing and collaborate on it, I think it could impact for many people on their adherence and the likelihood of relapse. So, Bob, I don't know if there's any questions come through or if anyone else has got any questions about anything I've said.
Yes, so I'm waiting for any specific questions, but here's a really, I think, an important general question, which is about the internet.
Yeah.
So much information available on the internet that's not helpful.
Mm.
How do we work with family members to correct misinformation? I'm pretty sure you can find any kind of misinformation you want to on the internet. Whatever you're looking for to support your view, you're going to find.
Oh, absolutely. There's so much misinformation and it tends to not be balanced. So anybody can go on the internet and say anything they like, and you can find a link, or you can find a link on TikTok for some guy saying that such and such a medicine causes bowel cancer. It might have no evidence at all, but a person reading it thinks, oh, wow, that's not good. So always I'm suggesting that people go to more reputable sites. You know, if anybody can say anything, we can't believe it all. So like we quoted the American Psychiatric Association, they're saying, despite this controversy, these medicines do work for depression. Now that's actually quite useful. So I'm almost always saying go for more mainstream sites which have some kind of scientific basis, because you can find anything and you can find things which are extremely negative and harmful.
Great. So I may have missed some specific questions, but there was, oh, so here's one. Oh, here's a couple coming in. Hold on. So this is a question about how to handle a family member who is requesting to be in charge of their medicine. Oh, hold on. Oh, this is this. Okay, so let me restate this. This is about when someone wants someone else to be in charge of their medicine.
Yeah.
And but it turns into kind of a bit of a control enforcement conflict, where suddenly I'm assuming there's sort of a struggle about, you know, who's in charge of the medicine. Any thoughts about that?
Well, it kind of depends on why that arrangement has arisen. So there are some people who their cognitive problems are such that they just don't remember to take it. And so they're forgetting it all the time. So then it is a really good idea to ask someone else to remind them or to bring the medicine to them, but because they're not remembering. But it sounds like there's at least ambivalence there. Now, there's often ambivalence there. We're often working with that. And the kind of collaborative discussion I'm trying to have is to discuss the two sides of this. So, for example, the pillbox that plays a tune, you would think could get over that problem and could become a source of joint interest. Because if you're putting somebody in a position of control, in my experience, that is often done so you can fight against that control. And that becomes counterproductive for both parties. So control is a very interesting one. So is there a way through this where the control can be shared? So maybe if it's mum can say, we've got the pillbox that plays the tune. We've put a really good tune on it. I think you like Led Zeppelin. So we've got Led Zeppelin on here. And probably the audience don't remember Led Zeppelin, but we've got Led Zeppelin on here. So when Led Zeppelin play, 10 o'clock at night, that means you take that tablet. Okay? How's that sound? The control is shared rather than something that can be fought about. I would really try to come to that. In the video, Eve tried to pull me into that kind of situation of, okay, am I going to take them all for a week, or am I going to take none? I want to be in control. And she tried to get me take control. And I eventually said, okay, so what are you going to do in the next week? Are you going to try and aim for 3 or 4? And she said, no, I'm going to try and take the full week. So control's a tricky one. Let's try and find shared control.
Okay, I'm looking for any other general questions.
Well, there's only 7 minutes left, Bob. You can ask a question. Or Deborah can ask a question, or Molly can ask a question.
Okay, yeah. Any questions specific to how to communicate, communication issues about medicine?
I'm not adding a question because Bob already conveyed mine. Buried in his questions were a couple from me.
Okay, yeah. So here's a question about when someone really doesn't have insight and really denies their psychotic experiences. Yeah. How do you even get them to consider medication?
Well, this is a great question, isn't it?
It is.
So there's 3 strands to insight. First of all is the insight into the fact that my symptoms are actually part of me and not something that's out there. There's insight into the nature of psychotic experience. And the next bit is the insight that you've had some kind of nervous breakdown, something that's happened to you mentally. Do you have insight into that? And the third bit is the insight into the fact that medicine is appropriate for you at this point in time. Now, perhaps surprisingly, these don't all run hand in hand, these 3 strands. So I've got people in my clinic who have very little insight, but take their depot every month. And they come in to see me and they tell me all about the strange experiences that they have. And are you okay with the depot? Yeah, it's fine. So why are they doing that? Well, partly I suspect it's because of the social contact with the nurse who's coming out. Partly I think they're probably not got a lot of side effects. They're probably getting something out of the medicine. And partly it's because they don't mind seeing me once every couple of months to talk about their experiences. So loss of insight into the nature of your experiences or into the fact that you've got a mental illness doesn't necessarily mean that you won't take medication. And it cuts the other way around. You can absolutely believe that you've got an illness and adamantly refuse medication. So it's an interesting subject, but I would certainly approach it in this way. If someone has no insight and they say, right, now the aliens, I hear them talking, they're about in the neighborhood, and I really think they're going to abduct me and kill me. So I would be saying, this must be hugely stressful what you're going through. Can you tell me about your emotional state? And they might say, yeah, my heart's pounding. I hardly sleep. I feel tense all the time. And I might then say, so surely in this situation, for you to be a bit more relaxed and able to concentrate better, it's going to be potentially safer for you. So would it not be wise for me to give you some kind of tranquilizing medicine It's not going to sedate you. You're going to be alert. You're going to be able to concentrate better. The heart won't be thumping. You'll be more relaxed. You might allow yourself a bit more longer periods of sleep. Would that not be a sensible thing at this point? So in that, I'm not challenging. I'm just saying in their particular life situation, while we investigate it together using CBT, which would run in parallel with this, would that medicine not be a good idea? And a lot of times I say that, and the person says, no, it wouldn't, thanks very much. And a lot of times I say it, they say, yeah, you've got a point. I'll have a low dose of that. Well, let's try a bit of that. The question here is time, isn't it? Because some of the things I'm talking about take a lot of time before the person changes. Sometimes you do one of these interventions and they actually change quite surprisingly quickly, and adherence can improve. Other times it takes ages of plugging away at it, and then something sinks in and the adherence changes and the CBT might change.
Great. And Doug, in this case, the person is adding that they do take their medicine, but they deny their illness. So it's kind of consistent with what you're saying. Somehow they're taking the medicine, but they just don't think they're ill.
Yeah. So I would think CBT would be great and family therapy would be great in that situation, because obviously it's a stressful situation for that person to be in. And so would it be good to have someone to talk through what's going on? So the job of the CBT therapist is to get their foot in the door and to start to engage the person and engage the family to see how that situation could move forward, because that to me sounds hopeful. Insight fluctuates and changes over time. And if you go long enough down the road, their insight will be a lot better. So there are opportunities for individual and family therapy there. These are great questions, Bob. I really appreciate them.
We'll do one last one.
Sure.
Which is, I think, a great one. This is about the person is quite willing to take their medicine, but they really don't want to do anything else. No therapy, no exercise, no behavioral change, just the medicine.
Just the medicine. So I would be interested to know if that medicine was having a side effect of sedation or weight gain or cognitive side effects. Because normally the purpose of an antipsychotic is to trigger a recovery trajectory. So I'm just wondering if that's side effects. So if it's something sedative and something that causes weight gain, would it be worthwhile thinking about a shift to something slightly more stimulant that doesn't cause weight gain? Now, I don't know enough here to be sure about that, but it may be that that's the situation. The CBT approach to this would be, if they're on the right medication, can we find any old hobby or area of interest that we could reactivate? Is there anything from the past? I remember one chap I saw, and he was lying in his bed. I mean, he didn't get out of his bed. He did take his medicine. He didn't get out of his bed. And I saw a book up on his bookshelf, which was about bird watching. And I said, oh, what's that book you've got there? Oh, he says, oh, I used to watch birds and stuff. I said, well, can you tell me about birds? What kind of birds do we have here? Oh, he said, outside the window there, we've got a bluebird and a magpie. And he started pointing them out. And so I encouraged him to start to write down the type of birds that he saw. And he actually got out of his bed to start writing down some other birds that he could see out the window. And this was a start. So sometimes you've got to get a start to getting back into life. You can become incredibly stuck because of the disorder and the stigma, maybe side effects, maybe symptoms. But sometimes there's a key which a family member might be able to unlock, like I did with the bird watching thing. That guy is actually gone out now looking for various birds and taking pictures of them. It took a long time, it took a few years for him to do that, but that was the start. So it's bringing medicines and CBT together.
Okay, we're probably going to have to wrap up the questions.
I think there's a hand up there, Bob, with a
Yeah,
question.
no, I think we've answered those questions. I think
Okay.
yeah.
Okay, so thanks for listening, everybody. I hope there was something there that was of interest.
Okay.
Do you want to close the show, Bob, or is Deborah going to do that?
Yeah.
But, Doug, I think there was one more slide where you had a reference for people.
Oh,
Yeah.
Yes.
well, it's actually in volume 1, which is the red one there. It's got a chapter called Tablets and Injections. It's chapter 6 on that first recovery manual, which tells you a lot about the CBT side of what I've been talking about today. And here's some other things. Peter Wyden is the great psychiatrist guy who's spent his whole life doing stuff around adherence. And he's a great expert in this subject. So this book chapter I've written with him is useful. Peter Wyden's a antipsychotic adherence intervention, the one I showed. He did that one. Compliance therapy is it's in the British Journal of Psychiatry, and that book chapter there by Richard Gray in a chapter 1 of Back to Life, Back to Normality. Well, I think we've had all our questions and all our ideas.
Yeah. Okay, I think I'm gonna close up here. Dr. Turkington, thank you so much for the webinar today. Fantastic topic. There was a lot of interest, some questions we couldn't get to. I'm going to encourage everyone to go right to the survey, which is linked here in your materials. If you could give us feedback and do it right away, we'd really appreciate it. We're aiming to get 100% response because we use this feedback to design a whole new series. So we'd love to hear from you. It's going to be very meaningful to us. You could kind of give back to us in 2 ways. One is give us feedback on the survey by clicking the link. The link is in your chat. And secondly, consider a donation to NAMI Moran. Again, Dr. Turkington, thank you so much for spending time with us. Fantastic webinar today. Okay.
Thanks for all listening
Thank you.
to all of that and
Okay.
being here today. And I wish you all the best for your Friday and your weekend.
Okay. Bye, everyone.
Bye, everybody.